So my topic for today is spectrum of MSK ultrasound. So this is one aspect of ultrasound which is rarely discussed. A lot of times we deal with adults, and it is very interesting to realize that this is a part of an MSK that also needs to be studied and to be learned, knowing that we also can see pediatric patients a lot of times in our practice. So let me just discuss today the spectrum of pediatric MSK ultrasound. And let me begin by reading a Bible verse found in Isaiah 40, 30, and 31. It says, "Even the youth shall faint and be weary, and the young shall utterly fall. But they that wait upon the Lord shall renew their strength. They shall mount up with wings as eagles. They shall run and not be weary, and they shall walk and not faint." This is a very inspiring message that all of us needs, especially in these challenging times. So what is this ultrasound in pediatric patients? So this is not a miniature adult MSK ultrasound. So we cannot simply just think about this as a pediatric version of the adult MSK ultrasound, because it has its unique features and would be very interesting to know that this one could also be a challenging way of diagnosing our patients. But this is also an extension of the physical examination. So whatever physical examination we've done and we have questions with regards to that, then we can use this as an extension of our examination. Then we would like also to monitor the changes of the developing musculoskeletal structures. You would like to know what are the structures that are usually abnormal, and you would like to see if there are other changes that we also note in the ultrasound. And then this is also a way to visualize structures like your cartilage or epiphysis. And interestingly, this is the primary imaging modality in infants with developmental dysplasia of the hip. So if we are dealing with patients with suspected hip deformation or dysplasia, then we can make use of this as a way of diagnosing our patients with these problems. Now, there are different spectrum of MSK ultrasound, and one of them is your cartilage. Number two is your bone erosions. Then we have synovitis, we have enthesitis, we have tendon, we have muscle, and we have peripheral nerves. All of these may have different characteristics as we use ultrasound. Now, number one is cartilage. Now, if you look at these images, as you all know, in the adults, when we see the tendon, we right away see the attachment of the tendon directly to the bone. But in this case, in young patients, there is an intervening cartilage that you see between your tendon and your bone, and this is your cartilage. And usually they are thicker at a young age than it is when it's older. So over time, the cartilage decreases with advancing age. And then of course, there's also some changes that you see that may sometimes confuse you as to whether you're dealing with an abnormal cartilage or not. But suffice it to know that for this particular stage, if there is any neovascularization, for instance, that is not indicative of any abnormality at all. So this cartilage, especially the apophyseal ones, the one that is attaching to your tendon and your bone, disappears between 8 to 15 years old. So don't expect it to be there. So what remains actually are the cartilages in the joints that are characterized as either your hyaline or fibrocartilage, but the apophyseal cartilage that attaches the tendon and the bone usually disappears on a certain age. Now, of course, the Doppler flow may be normal in healthy children. So if you see some Doppler findings there, it doesn't mean that you are dealing it may mean that you're dealing with an abnormality, but actually it's not anymore an abnormality, but it's just a healthy physiologic findings. And of course, cartilage is also used to assess the thickness, and the best site for that is, of course, at the intercondylar notch of the knee. And you will notice here in this ultrasound findings that it is narrowed at the middle portion, that it is in the peripheral. So sometimes over time, as it thins out, you will notice that the femoral cartilage is a very good way of assessing whether you're dealing with an osteoarthritic change or not. Also, this cartilage findings is an indicator of a joint damage, which is found usually in juvenile inflammatory arthritis. And of course, this is also found when there is a follow-up of a therapy that is provided for the patient. So we need to find out whether we're dealing with a good response or there is no response at all when we give medications for our patients. Now, radiographically, bone erosions does not appear until the bones are 30% damaged. So if you look at bone erosions in the X-ray and we see some changes there, that means 30% of it have been missed. So it may not be a good way of detecting bone erosion. So here we can see that ultrasound has a very important role in detecting bone erosions, although the more sensitive ones is the MRI. But the only advantage of ultrasound is its portability. We can do it anytime, anywhere, and we can already give patients whatever concerns they have. Then, of course, the OMERACT has mentioned that if the bone erosion is less than 1 millimeter, it is not considered a bone erosion. And so anything that is more than that is the one that is valid. And the characterization is that it is usually seen either at the dorsal or dorsal aspect, and it could be unifocal, or it could be multifocal, it could be massive. And if you are looking at the signs for early rheumatoid arthritis, for example, the best place to check that is at the 5th metatarsal head, where it is most frequent. And of course, it is highest number of erosions found there. And of course, in chronic, you can also check it at the 2nd metacarpal bone. So these areas are very accessible, and you can easily find it there, and you can already see all these findings to be present. Now, the other thing is the scoring system for bone erosions. Now, we have two very common scoring systems. For example, if we are dealing with larger lesions, then we can use the SCUSSE, SCUUSSE. So it's scoring by ultrasound structural erosion system. And this is only limited for larger lesions. But for other lesions, especially for small subtle lesions, we can use the scalaric scoring system. And this could be validated by CT scan. And it has a very good inter-observer reliability rate of about 91%. So if we are doubtful about our results, then we can counter-check it with our CT scan, which will objectively give us a correlation on that. The other thing, of course, is synovitis. Synovitis is one area in pediatrics which is very important because this can make or break any findings that we see, especially if we are dealing with juvenile rheumatoid arthritis. So there are three things here that we need to differentiate. We have the synovitis, synovial fluid, and synovial hypertrophy. So what is synovitis? Usually it's a non-displaceable and poorly compressible characterization in the ultrasound. So when we put the probe, for example, and then we see some echogenicity, usually it's hypoechoic, I should say. So the tissue, even if we apply the probe and try to put pressure on it, it could not be displaced. But if you put a power Doppler, then you can see some vascularization, characterization that we see in the joint. So that is a characterization of how a synovitis really looks like. How about a synovial fluid? A synovial fluid usually are hypoechoic to anechoic intra-articular material, And this is basically very displaceable, very compressible, but there is no Doppler signal. So that is how you can differentiate the synovitis. How about hypertrophy? Hypertrophy is just a swelling of the synovial lining, but this is also non-displaceable and poorly compressible and no Doppler signal. So a synovitis is an inflamed synovial layer, okay? It could be also hypoechoic thickening, but there will be no Doppler signal if it is just a synovial hypertrophy. But if it is synovitis, there will always be a Doppler signal. Now, the synovial fluid example is this one. That's a suprapatellar part of the knee. As you can see here, it is between your quadriceps muscle and your prefemoral fat pad, and it is usually anechoic, and this is an extension of the knee fluid. So you can see here to be really, really black. Now, this is an example of synovial hypertrophy. You can actually measure it, and so there is a thickening of the synovial lining. Usually, the synovial lining is only one cell layer. That's the normal. So you don't actually, you cannot even measure it. But the moment it becomes chronically inflamed, synovial hypertrophy sets in. So you can see it to be very thick, and this is exactly what you see here. There is a synovial thickening of the layer in the joint, and that is a synovial hypertrophy. It could be converted into a synovitis eventually, where there is neovascularization, and that could not be also compressed, and that could not be displaced. Okay, this is an example of a synovitis. And so as you can see here, if you put the power Doppler, you can see the highlight, the neovascularization, the inflammatory process, and the degree of inflammatory activity is very obvious here. And here you can use this for two reasons: to identify an inflammatory process, and of course, to monitor the progress of a rheumatoid response to therapy. So when you actually monitor it, you will see if your medication is working or not. Now, the other thing here in the pediatric MSK is your enthesis. Now, the enthesis is an organ by itself. This is an attachment of the tendon to the bone. And as you can see, it has two types. It could be a dense fibrous or a fibrocartilaginous. What are the differences? The dense fibrous is similar to tendon's mid-substance. It directly attaches to the bone or periosteum through a fibrous tissue. And the fibrocartilaginous it attaches to the bone through a layer of fibrocartilage transitioning from the fibrous tissue to the bone. And this is where the majority of our tendons are attached, like your rotator cuff or your Achilles tendon. Now, if you look at this graph, you will notice here that the characterization of fibrous and cartilaginous enthesis is made. So let's say, for example, for fibrous tissue, the common attachment is at the metaphysis and diaphysis of long bones. But in fibrocartilaginous, it usually attaches at the epiphysis and apophysis. The composition of fibrous is it perforates in mineralized collagen fibers, and the fibrocartilaginous, it has 4 distinct zones. And the angle of insertion is usually changes during slight motions in fibrous, but in fibrocartilaginous, it is prone to overuse injuries as the insertion angle changes are greater. And of course, in the fibrous, an example is a deltoid, and of course, adductor magnus. In the fibrocartilaginous, an example is, of course, rotator cuff and Achilles tendon. So here is an highlighted area of the fibrocartilaginous attachment. So you can see here the tendons attaching to the uncalcified fibrocartilaginous, and there is a tide mark. This is really a transition of the tendon towards the bone, wherein after that you have the calcified fibrocartilaginous layers, and then you have the bone. So here, it is very important to notice that you can actually see all these changes only in the fibrocartilaginous, but not in the fibers. Okay, so here are other details of those which we have described between the composition of the fibrocartilaginous and how are they differentiated from each others. So the zone 4, as you can see here, are the ones is the one that provides sites of attachment for the tendon. But the tide mark is the demarcation between what is considered to be an uncalcified layer versus the calcified layer, which is the boundary between the soft and hard tissue. Okay, now these are the different layers that we mentioned in the enthesis, but when we look at the ultrasound, you will notice that it's hardly distinguishable. So what you can only see is the Achilles tendon that is directly attached to the apophyseal cartilage, as we mentioned it earlier, that disappears as we age. So the enthesial thickness usually, which is part of the Achilles tendon, will thicken with age. So this is very important because this is where a lot of our forces are transmitted when we actually move, especially during jumping. So it has to be tough in order to withstand the forces that is happening during our movement. Now, the power Doppler present in peri-enthesial areas as the apophyseal physis closes. So we need to understand that. And there is a caution of making a diagnosis of enthesitis if we actually see some changes in the power Doppler in these areas. We might think this is an enthesitis, but this is just the areas where there is a peri-enthesial or the closure of these peri-enthesial areas. As we mentioned earlier also, ultrasound is an extension of our physical examination. Whatever we find in the physical examination should be also proven and validated in the examination here. Now, so this one is typical enthesitis findings. So the signs include localized pain, tenderness, and swelling by physical examination. But by ultrasound, you can see it as an enhanced vascularization. There is an erosion, there are cortical irregularities, there are calcifications, there is a fibrous scar formation, and then the tendon in the ligament may appear to be hypoechoic with capsular thickening. So remember that to be some signs that you can see in the enthesis. Now, ultrasound, fortunately, can detect subclinical diseases, okay? Now, this particular video, or should I say image, is a patient of mine who suffered from a recurrent pain on the calcaneal area, which we thought is, or the patient thought, and the pediatrician thought is just growing pain. But actually, I was very curious to find out what is happening. So he's got a very inflamed Achilles tendon attachment, which eventually we found out to be actually an early part of a Sever's disease. So in GIA, or juvenile inflammatory arthritis, you can also check this enthesitis in order of onset from the plantar fascia. Then it may affect the Achilles tendon, the tibial tuberosity, and the patellar attachment. So all of these areas could be assessed in order to see what are the changes that's happening in those areas. Now, about tendinosis, ultrasound will show a hypoechoic swelling and loss of fibrillary pattern, which is common in juvenile rheumatoid arthritis. In children, there are also injuries at the tendon affecting also the apophysis. So here, if you will notice, this is from Pisacano, you will notice that on the left side is the normal side, no other hypoechoic swelling. There are no other changes. But here on the right side, you will notice that there is vascularity that is seen, and there is a hypoechoic swelling of the tendon on each attached area, on the attachment area. How about the muscle? In the muscle tissue, the muscle is useful in assessing neuromuscular disorders, and myopathies. Can you imagine? The ultrasound can also diagnose those things. In this drawing, for example, in this image, for example, on the left side of the screen, you have the normal muscle tissue, and on the right side, you can see an echogenic fatty infiltrated tissue because of neuromuscular diseases or disorders. And it is very significant to notice that a normal starry night pattern of the muscle have disappeared, and it was actually infiltrated by a lot of fats and connective tissue. That's why you can see it to be echogenic. Okay, so muscle thickness is also used as measurement in assessing neuromuscular disorders and myopathies. So in ultrasound, myopathies appear hyperechoic. In neuromuscular disorders, the muscle fascicles are replaced by fats and connective tissue with increased number of perimecial septa. So ultrasound has a sensitivity of 67% to 81%. So it's not really very sensitive, but it could at least differentiate a normal muscle from an abnormal muscle. This is a position statement of the American Association of Neuromuscular and Electrodiagnostic Medicine, which says that the ability to sensitively evaluate muscle disease has also improved to the point that now it is possible to image fasciculations of muscle and also fibrillations. So using dynamic imaging, if you put the probe on an area where you suspect fasciculations, you can actually see the muscle moving. And you can also see those small fibrillations in the muscle by ultrasound. So this is a very interesting finding, because even as we say that EMG can record and document fibrillations and fasciculations, the ultrasound can also show that in their images, in a dynamic images. So it's very interesting to compare how these two findings could correlate and come up with a specific diagnosis. So let's go to the nerve. The nerve almost appear the same for adults and children. They are also characterized by a honeycomb pattern in a short axis view. And then there are fascicles in between made up, and then also connective tissue, which are the ones that you appear to be white. And in the long axis view, you can see a long axis pattern, and it's a trilaminar pattern. Here you see the echogenic peripheral side, and then hypoechoic at the middle portion of the nerve, which indicates that this is really a normal nerve. There are no notching seen here. So this is also another view of the normal ultrasound, which we see in the patient. It's as I bend the cross-sectional area is honeycomb. The long axis view is also no notching and usually uniform in their size. So we use a high frequency probe, more than 10 megahertz, and ultrasound will show hypoechoic swelling, proximal to entrapment sites, loss of fascicular patterns, increased echogenicity of distal denervated muscles, and later with decreased muscle size. So this one is showing to us the changes that happens if there is a denervation. And the nerve here will become swollen, but at the same time, there is loss of fascicular patterns. But look at the muscle. The muscle will appear echogenic, and eventually the size will decrease. Okay, in children, this is seen in hereditary sensory motor neuropathy with strong correlation as to the severity and increased CSA. There is also a focal nerve enlargement, which is a characteristic finding in hereditary neuropathy. So in EMG, there is a decrease in nerve conduction velocity, which corresponds in ultrasound as an increased cross-sectional area. So very interesting. So EMG versus ultrasound, when MSK ultrasound is added to EMG, the sensitivity increases from 78% to 98%, and additionally localizes lesions not identified with EMG. Now we're moving to a more exciting part of this lecture, which is the developmental hip dysplasia or developmental dysplasia of the hip. In the past, what we use normally is the X-ray. And if you are still familiar with all these lines, let me just give a review to all of you. Okay, so we are using the triradiate ligament to be the center of the axis. And then passing through those axes horizontally is the Hilgen-Reiner's line. And then we have the vertical line, which is referred to as the Perkins line. And we have the curved line at the lower portion, which we call the S. Shenton's line. And also we form an angle there that goes all the way to the roof that is called the acetabular index, which is normally less than 26 degrees in males and less than 30 degrees in females. And we say it is normal if the femoral head is found at the inner lower quadrant of that angle. Okay, so in this case, you will notice that the dislocated hip has a dislocation of the femoral head. It goes way up there, but in the left side, which is a normal hip, the femoral head is found still at the inner lower quadrant. But there are other physical examination that we see to be present. We have a shorter thigh, extra skin folds, loss of the mild knee and hip flexion, and then of course what we usually do, the Ortolani and Barlow's test. But this is not always accurate. The Ortolani and Barlow's test, the clunk that we hear in those tests may not necessarily indicate that there is dislocation that's happening, but it could be caused by other structures inside, and we will discuss that later on. So here, this is a recommendation guidelines for developmental dysplasia of the hip. That is a joint recommendation by 3 associations: the American Academy of Orthopedic Surgeons, American Academy of Pediatrics, and American Institute of Ultrasound in Medicine. So what they were saying is that ultrasound screening for this developmental dysplasia of the hip is not recommended as an adjunct to the clinical exam, not yet, all of them, but the first ultrasound should be done. If you will notice their suggestion, it should be within or after 2 weeks. And you will later on realize that the best timing is actually 8 weeks, based on studies, of course. And you can see here the other risk factors that is mentioned: breast delivery, female, and of course the presence of Ortolani and Barlow's positive exam. So all of those things are very important. And of course, we have 2 types of doing it. By ultrasound, we either use the Graf method or the Harcke method. The Graf method are the ones preferred in Europe. The Harcke method is the one preferred in the US. So depending on what you want, you can use both. Okay, the risk factors include breech delivery, positive family history, female gender. So these are the risk factors. And with the developmental hip dysplasia, 60% of the time it's found on the left. Okay, so just remember that. 20% of the time it's found the right hip, and 20% of the time it's bilateral. So why are we interested to know all this? Why do we need to diagnose them? Because it's been found out that the long-term effects of this dysplasia of the hip is hip deformity, gait disturbance, premature arthritis, and of course, one thing that we don't really like is the potential joint replacement surgery. So if we can avoid this, then that would serve a good purpose for our children, especially if the child is our kid. Okay, so the hip clicks in newborn. We usually hear these clicks, 10% incidence in newborn, but it usually result in less than a year. So if we have a click, we can actually follow them up, but it could result in less than a year. Okay, so that's based on studies. But currently, ultrasound is used for the diagnosis of early stage of instability or subluxation, especially if it is present at birth, I mean the click. So clicks doesn't need to be treated, but it has to be monitored. So we know also that the Ortolani, it's a relocation test, the Barlow's is a dislocation test. 15% of hip dysplasia is not detectable at birth. So we have to keep repeating it during the first year of life. 17.8% prevalence by ultrasound in neonates. The click does not indicate hip dysplasia. It could be due to the other thing. So here I listed intracapsular and extracapsular causes. So let's begin with intracapsular. So intracapsular causes of clicks could be due to ligamentum teres, pulvinar, or labrum. Extracapsular, it could be due to iliopsoas tendon, tensor fascia, or it could be referred from the knee. So these are sites, and you can see here that these findings are found in research done by Dr. Gaffney, very late. This is the latest one, just this year, 2020. So this is very relevant. So when do you do the ultrasound? So the best timing to do ultrasound for the hip is 8 weeks after birth. This is the optimum period to do ultrasound in order to make sure that we're dealing with hip dysplasia. So how do you do this? Okay, the first one, of course, is the Graf method. This is what is very common in Europe. So baby lies in lateral decubitus position, but sometimes it's very hard to make the patient lie in that position. So you might be the one to adjust. You can take the patient's scan in whatever positions as you like, for as long as your probe is in the coronal position of the femoral hip. So just like what is shown here in the image here. So it's hard to talk with a child. Try to play with the child first until the child feels comfortable with the probe, and that assures him that it's not harmful to him, and then you can begin. So you do a coronal scan, and you go to the deepest point of the acetabulum, hip slightly internal rotated or neutral, and knee slightly flexed. Approach is posterolateral. So since you are looking at the deepest portion, then you can see other muscles. You can see the gluteus medius, you can see the minimus, the joint capsule, the femoral head, and then of course the triradiate ligament, which is really the deepest part or the deepest point of the acetabulum, okay? And that is where it actually intersects, and it also shows in the drawing there, just below the ilium, okay, or the promontory, okay, that is the triradiate cartilage or the ligament. So Harcke's method is the one that makes use of instability as the main abnormality for monitoring, common in ultrasound in the US, and in Europe. We use Grafs, which is a morphologic way of assessing the developmental hip dysplasia. Harcke is dynamic, Graf is static. So that's their difference. Okay, let's begin with Graf's method. So you see all of these lines and angles later on, okay? So let's begin with the references. So you can see first the femoral head. So as you can see, it's rounded, and then you can see an echogenic line to your left. That is your iliac wing, okay? Then of course, you can see just below the iliac wing, the promontory, that is the angle, okay? And then just below that promontory, there is that echogenic structure, which is your bony acetabular roof. So if you consider this as a roof, then you will notice that this is actually the reverse. In other words, this area below is actually the one that is on top, and the one on the opposite side is the one that is below. And then on the opposite side, just above the ilium, that refers to the C there, if you'll notice that is the fibrocartilaginous labrum. So that's the labrum there. The labrum above, bony acetabular roof below, the line to your left is your iliac wing, and the rounded area is the femoral head. So if you try to picture that, that is exactly how you see a typical hip dysplasia ultrasound scanning. So it should always appear like that. Okay, then from this drawing, we draw now the angles. So you can identify here two angles. We have the alpha angle and we have the beta angle. So alpha angle is formed by the ilium and of course by a line drawn crossing through the promontory from the acetabular roof line. Okay, so if you notice that, that forms your alpha angle. So remember that, the ilium to your left, the acetabular roof crossing through the promontory, which forms really the angle there, that is what you call the alpha angle. And usually the alpha angle should be always more than 60 degrees to say that it is normal, okay? So in other words, if you move your alpha angle more, that means you are putting the femoral head more. You are not displacing it. But if you decrease the alpha angle, you are pushing the femoral head out. And so you are displacing the femoral head and you are developing dysplasia. Okay, what about the other angle, the beta angle? The beta angle is on the opposite side. And if you'll notice, the ilium there, and there is also that labrum on the top, right? There is that labrum on the top. So it crosses also at the promontory. So it forms an angle that is formed by the ilium drawn, passing through that promontory, and then the labrum crossing through the promontory. The angle formed is the beta angle. So it's described as the cartilaginous coverage of the femoral head. So it's the one that kind of covered the femoral head. So it has to be less than 55 degrees, okay? Because if you open it up and it is more than 55 degrees, then that means you are allowing the femoral head to go out and forming a dysplastic hip. Therefore, the lesser the alpha angle, the greater the tendency of the femoral head to dislocate, okay? Moreover, the higher the beta angle, the higher the displacement of the femoral head from the acetabulum. So alpha, we want it to be higher. Beta, we would like it to be lower, okay? So, just for you to see how exactly it is oriented, I decided to put this here because if you will notice, in the image on the left, that is your femoral head. Of course, you have there the promontory, and then of course you have there the ilium, you have there the acetabular roof or cartilage, and then you have the greater tuberosity, that's the echogenic on your right. So the direction of the leg is going sideways or diagonally to the right, okay? So that is how it is oriented. So you will have a picture of what is this image I'm looking at. I cannot orient myself. So at least you know exactly where it's going. So the beta angle indicates superior displacement of femoral head. So we're saying if you have lower beta angle, it's better because it keeps the femoral head inside. But if you have higher beta angle, you allow the femoral head to move up, okay? In contrast to that, the alpha angle, you want it to be higher because you are putting more space to the femoral head to stay inside. Because if the alpha angle is less, that means you're trying to push it out from the joint. So what is type 1? Type 1 is just actually normal. Type 2, this is classified into type 2A, 2B, 2C, but you know, with different angles. This type of findings up to about 43 degrees can be classified as slightly dysplastic that could resolve spontaneously. So no problem. If your degree is 43 degrees up to about 50, okay, that is almost 20 degrees less from 60, then you can just tell your patient, okay, this can resolve spontaneously, but sometimes your patient or the parents are very concerned. So you can suggest that you might want to put them on a Pavlik harness. So maybe for 2 months, just to make sure. Now, if your value is less than 43 and below, then that is really requiring some kind of a treatment, especially with Pavlik harness again, okay? So those are the angles and their gradings. Now, this is just an example of a normal. As you can see here, even if you don't measure it, you know that the femoral head is displaced, okay? The alpha angle in this case is less than 60 degrees, which is 44 degrees. The beta angle is 54. So it's really putting the femoral head out. So we would call this a subluxed femoral head. Okay, now let's move on to Harcke, Dr. Harcke. Dr. Harcke, an American, okay, made a different dynamic evaluation. And so what he did was to measure the different depths here. So the first D, the capital D, refers to the diameter of the femoral head. Okay, so the distance from the top to the bottom of the femoral head, that's your capital D. So for normal patients, we have the small d, which is just the acetabular depth. So this is just the depth from the ilium to your triradiate cartilage. So as you can see, if the ratio of the d over d is more than 50%, in this case it's 65%, they would consider that as normal. Okay? So normal value means 58% or greater, normal. But just in case it displaces our sublux, you will notice here now 2D. The first D is the original D, which means it should have been the distance from the triradiate to the ilium. But in this case, we have a D with an asterisk, which is actually the actual displacement of the femoral head from where it begins, okay, to where it displaces, because it measures actually the distance from where the femoral head starts inferiorly until the ilium line, the iliac line. Remember the iliac line? So that is referred to as the femoral head coverage. Now, you have to get the ratio of the D without the asterisk, okay, over the femoral head diameter, and this is about 45%, which is actually less than 50. So you consider this as a subluxed femoral head, as you can see it here. So this is done with the hip in neutral position. In other words, the hip is not flexed, okay? But here, I'm gonna show you what if you actually stress it. You stress it by flexing the hip. So when you flex the hip, this is what happens. So you kind of move it more, and you can see it that as we compare it from the previous one, which is 30%, now it becomes 27%. So it's really dislocated. In other words, there are times when you are not convinced that maybe the hip is not really, you know, plus and minus, not displaced, not dysplastic. But as you can see from here, that you can do a stress test by flexing the hip, and then you can measure it again and then come up with a diagnosis. So this is really a subluxated or dislocated femoral head. Okay, so comparing both and correlating both, this is now what we come up with. The alpha angle correlates with the ratio of D over D in the coronal neutral view. Okay, so in other words, if you're looking at alpha angle, this alpha angle that you want to be more than 60 degrees, okay, means that we have also a good more than 50% D over D ratio in the coronal neutral view. Hence, the ratio of D over D of more than 50% correlated with good acetabular development. And then, of course, if you would like to make sure, because if we're doubting, we can do a stress view, okay? And the stress view is by flexing the hip and then getting, again, all those distances, and then come up with the ratio, and then checking if it is within the normal or abnormal. So that is just one way of trying to make sure that we don't miss anything by doing the stress view, okay? Now, this is a patient, a 4-month-old patient that it's treated with public harness. And you look at the X-ray with an acetabular index of 34 degrees. on the left and 39 degrees on the right. And as you can see here, there is a notching defect at the promontory, noted by the arrow, and it is echogenic. Okay, in other words, there is something there that happens, so causing a defect, okay? And after the treatment with public harness, you can see here that the ratio based on Harcke's method is more than 50%. In fact, it's 52% on the right and 60 to 66% on the left. They did a flexion stress view, so that is really, really good, okay? So you can see here that it responds with a public harness. So for those of you who are not acquainted with this harness, this is how it looks like. So what is the purpose of this harness? The purpose of this harness is primarily just to flex the hip and abduct the hip in order to keep the femoral head inside the acetabulum. So that is exactly why we put this kind of harness. We want to make sure that the femoral head is inside the acetabulum, and the only way to do that is to abduct the hip and to flex the hip. And that is what the public harness, it's a static type of brace to keep that femoral head inside. So this is a serial ultrasound of a patient where they did both a flexion view and together with an adduction stress, this time an adduction stress. And you will notice here that they actually measure not the ratio of the D over D, but they simply get the distance between the lower portion where the triradiate ligament is coming from and the movement of the femoral head. And you can see here that the actual gap is narrowing during about a matter of 10 weeks, maybe 2 months and 2 weeks, using a public harness. So you can see here that patient responds very well. In fact, it stabilizes over time when we actually use the correct method of trying to put the harness in place in order to help the patient with hip dysplasia recover from what seems to be a subluxed or dislocated hip. So you can see all the progression here over time, 1 week, 4 weeks, and 11 weeks, okay? So role of other imaging modalities. So X-ray and ultrasound. X-ray, of course, can be used still as a initial imaging modalities of choice. But if you want to really make sure to get all these angles and lines and distances, I'm sorry, I would recommend ultrasound. And of course, MRI is only useful for post-reduction assessment to confirm whether there is a stable reduction, a concentric one, and if there's any complications that happens after that. So this one is another example of a patient with an anterior knee pain, a 10-year-old boy complaining of pain there, and the ultrasound finally shows an infrapatellar bursal effusion. Okay, this is a deep infrapatellar because you can see the patellar tendon right above it. And then there's a swollen patellar tendon as well. And you can see the attachment. Okay, there are cortical irregularity on the attachment with a pain there. So what could this be? And the tibial tuberosity is really causing so much inflammation right there. So this is an example of an Osgood Schlatter disease. So patient is developing an early stage of Osgood Schlatter. So you can see that on ultrasound. So in summary, there are unique features that we need to see in pediatric MSK ultrasound, especially as we follow them as they develop, especially if you are monitoring some disease progression. It is very important to do monitoring use an ultrasound. And it should be noted that cartilage decreases over time, and Doppler may be normal in growing children. And less than 1 millimeter of bone erosion is not considered abnormal. And we need to understand the difference between synovitis, synovial fluid, and of course, synovial hypertrophy, also to differentiate enthesis versus enthesitis versus tendinosis. Muscles disease are usually echogenic. And of course, pediatric ultrasound is the primary diagnostic tool for diagnosing hip dysplasia. And this is used to monitor developmental changes in children. It can detect subclinical structures, changes structurally. This can help in monitoring effectively therapeutic interventions, especially when we're dealing with juvenile arthritis and some other diseases. It could be used side by side with other modalities such as MRI, CT scan, and EMG. So with all this, I would like to thank you, everyone. And for you, if you would like to see all of the lectures that I've given today, it's in my chapter in this book, Pediatric Musculoskeletal Ultrasonography. It was just released this year in Springer, London. So you can buy that online. You can get the online version. So you can put it in your iPad or Mac, or you can buy the hard drive, hard copy, I mean, that you can use for your own purpose of learning. So all of this could be found here, and some other things. Dr. Martinoli is part of this book. He wrote a chapter on shoulder ultrasound for children. Very nice chapter. So thank you very much for your kind attention, and have a good day.